Welcome to PROCURE Health Talks, a webinar specially designed for men affected by prostate cancer and their loved ones. The various topics covered in these webinars are intended to provide reliable information based on the concerns and questions asked to PROCURE healthcare professionals. Let's begin.
Hello and welcome to PROCURE's Health Talks. I'm Kim Sullivan, and today we are tackling the topic of recurrent prostate cancer, which is when your cancer comes back after you've had treatment that aimed to cure it. Sometimes, though, not all cancers is successfully treated, and or maybe a cancer may have been more advanced than first thought. So one thing is for sure, when a cancer comes back, our first question is, what's next, doctor? So we are very lucky to have somebody with us today that will answer questions that you may have. Dr. Armen Aprikian, he is the MUHC surgeon-urologist, clinical lead at McGill's Rose Center Network and president-elected of the Canadian Urological Association. Dr. Aprikian, thank you so much for your time and welcome to PROCURE Health Talks.
Thank you for having me, Kim. It's always a pleasure talking to people who are interested with what's new with respect to prostate cancer.
And it's also very scary to find out that you've already battled one battle and all of a sudden you have to battle a second one. So let's talk about this. We're going to start with a couple of general questions because I'm sure many people may have this on their mind. How do you know when a cancer has come back, and how long before you can actually detect the reoccurrence of it?
Well, first, maybe just to set the stage, just because cancer of the prostate comes back after the first treatment does not mean that that's the end. We have many opportunities for other treatments. So that's the first message, in that there's always a chance to treat it again successfully. Fortunately for men who have prostate cancer, the simple way to detect whether a cancer has come back or not is with a simple PSA blood test. So for example, if someone has had surgery for prostate cancer, normally the PSA count afterwards should be 0. And if it's not 0, that tells us something is going on. If they've had radiation treatment, for example, the PSA count should be under 1. And if it starts to rise, then that tells us something is happening. So if the PSA is 0, we don't need to do additional tests. If it's not 0 or it's rising after the first treatment, well, that tells us something is happening, and we do additional tests like scans.
So I'm sure many people going through this would have the question of, what's the percentage, doc? What's the percentage of recurrence of prostate cancer?
Yeah, that's a great question. So unfortunately, there's no one number. It depends on a few things. We kind of gauge the risk a cancer will come back after treatment based on some simple parameters. One is the PSA count. So we like it if the PSA count is below 10. We also gauge how much and what type of cancer we found on the biopsy. So if there's a lot of cancer on the biopsy, then we worry that the cancer can come back, a higher chance of it coming back. But most importantly is what's called the grade of the cancer, meaning how aggressive is the cancer looking when we examine it under the microscope after biopsy. And that grade is what drives the what we call the prognosis or the risk. In general, though, about 1/4 of the time, the cancer of the prostate can come back after it's been treated, either with radiation treatment or surgery.
So you just spoke about grade. So I have a question pertaining to that. Does that mean that when initially diagnosed, it's possible to know or suspect that this certain type of prostate cancer may have a higher recurrence because of that grade?
Exactly. So when we do a biopsy of the prostate, we do it for two reasons. One is to answer the question, do we or do we not find cancer? But second is, if there is cancer, what's the grade of the cancer? And we kind of measure the grade on a scale from 1 to 5, what we call the grade group. So if it's 1, That's good news. Even though it's a cancer, it's a low-grade cancer, a cancer that really doesn't pose much threat. And if it's a 5, that's the worst type, the most aggressive type, and we're very anxious and nervous about that kind. And of course, we've got the scale in between. And the higher the number, the more nervous we are about a cancer not being successfully treated.
And can you also know that where in the body that cancer has progressed to?
So in the setting of a rising PSA count after someone's been treated, we do tests and we look to see where is the PSA coming from. Are there signs of metastases, or is this what we call a local recurrence? A recurrence where the prostate used to be, or it's in the prostate where it was radiated. So we do traditional scans, a CT scan of the chest, the abdomen, the pelvis, looking for any lymph nodes or nodules anywhere like in the lungs. And we also do a traditional bone scan because that's one of the common places where cancer can spread to see if there's metastases in the bones. More often than not, when the PSA is starting to rise and we get nervous and we want to check, the PSA count is quite low when we first look at this. And when we do the scans, we oftentimes don't find anything, which is good. It means that the recurrence is relatively early. And then we have some choices as to how we can act on someone whose PSA is rising after initial treatment.
You talked about tests, and I know that technology is huge. It's what we are trying to fund. It's what we want to progress. There's this kind of imaging test. I might say this wrong. The PSMA TEP scan, showing where cancer cells are actually hiding. Can you tell us more about this test?
Yeah, so this is actually a very, very innovative and novel imaging test. So it's an antibody that recognizes an antigen that is expressed only by prostate cancer cells. So we inject someone with this antibody, and the antibody has a little bit of a signal on it that can be captured by a camera, like we do when we do PET scanning or TEP scanning in French. So this injection of the antibody goes through your body and looks to see where are the cells that are expressing the prostate cancer PSMA antigen. And because it's got a little signal on it, when we check with a camera, we can try and locate where the cells are expressing. So this is quite new. It's been around for a few years in the research setting. Now it's becoming more and more available in Quebec. Certain facilities do offer it, not all. It's not completely covered yet by the l'Assurance Maladie du Québec, but it will be soon. So that's something that a patient can ask their doctor are they an appropriate candidate for this special scan? And then the physician can locate certain places where the scan can get done.
Because this is the kind of imaging test that could be useful, let's say, after first-line treatments like radical surgery or radiation therapy to see where the cancer has come back.
Indeed. So oftentimes when we're not sure where is the cancer, this particular scan can be helpful. It's not perfect. It's better than some of the existing technologies. So we sometimes request that scan when we're not sure if something that we saw on a traditional scan, is this really where the cancer is coming from, the PSA coming from, and we want to confirm. The PSMA scan can be quite useful. In other scenarios, it doesn't help, and therefore we don't need it.
Okay. So it's good to note down and to actually ask PSMA TEP scan. So to ask our doctor about that one. I also read about salvation therapy. What does that mean? How does that work?
So salvage treatment is when we want to treat someone who has recurrent cancer after an initial treatment. So for example, A typical story would be someone who underwent surgery, and then a few years later, the PSA count starts to rise. We do a bunch of tests and cannot find where the PSA is coming from. And we assume the cells that are expressing the PSA and where it's recurrent is in the area where the prostate used to be, where the surgery was done. And then we do what's called radiation treatment to that part of the body to sterilize any cells that are trying to grow and come back. So that's called salvage radiation treatment. And the success rate is quite good as long as we don't wait too long and we don't allow the PSA count to go too high. So traditionally, we like to do the salvage treatment before the PSA reaches 1.0. That would be an appropriate time to do the salvage radiation. For men who went through radiation treatment as their main treatment and whose PSA starts to rise, we again do scans to see if there's cancer anywhere else. And if we don't find any, and there's still cancer in the prostate, well, salvage treatment would mean either removing the prostate in this setting, which is a bit complicated, or using newer techniques such as high-intensity focused ultrasound, cryotherapy, sometimes radiation again. So there's a variety of options to treat in the salvage setting.
We're talking about treating. Do we think that there is a chance that we can cure a recurrence?
Yes, so there's always a chance for cure. It's true that each time we treat, the chance of success is less and less. But in the salvage setting, there's still a good 50% chance that we can cure someone as long as the recurrence is picked up early and it's not an aggressive form of recurrence.
And I'm sure that's something that everyone going through this loves to hear, is that even though there is a recurrence, we can still aim for a cure, which is what we're all hoping for. Okay, let's talk about hormone therapy, because I know that that's used as a backbone treatment for non-metastatic prostate cancer. The gold standard treatment has come back for someone who isn't a candidate of salvation therapy is hormonal therapy, right?
Yeah, so that's it becomes a bit more complex now. So the traditional scenario is someone who went through, let's say, surgery, the cancer came back, had salvage radiation treatment, and unfortunately, the cancer came back again. Well, now the fallback is on hormone treatment. Now, hormone treatment is in general not curative, but it can control the cancer for many, many years. Some people more than 10 years. So it's almost as good as a cure in some men. Now, if, however, we do find where the cancer is, so again, for example, if someone went through surgery, a cancer came back, then we did salvage radiation. Unfortunately, the cancer came back, and we do scans and we find that there's a spot in a lymph node, for example, in the abdomen. Well, in addition to the hormone treatment, we could target that lymph node with radiation treatment. So we can do what's called targeted radiation to certain spots wherever we find them. However, as you pointed out, the backbone in this setting is traditional hormone treatment.
You were saying that hormone treatment is the backbone. We understand a bit of why. I would kind of like you to elaborate on that, but I would also like to know if someone has to go through hormonal therapy, is this something that is for life? Is this something that they have to continue for a long period of time, for those 10 years that they have of extra time? Is it permanent?
So that's a very good question, and we have options. In general, if the cancer has spread, meaning we find what we call metastases in the bones or in the lung or in a lot of lymph nodes, then we prefer keeping the hormone therapy continuously for life. And sometimes we even add additional treatment on top of the hormone treatment to maximize the benefit. However, in some situations, the side effects of the hormone treatment may be, for some men, not tolerable. And therefore, we do have the option of stopping the treatment as long as the PSA count went down to 0, for example, or on some imaging tests, things look much, much better. Then we sometimes can stop to allow the side effects to go away. But we know that when we do stop, usually the cancer will start to wake up, and then we'll have to restart again. So in those patients in whom we have metastases, we prefer continuous lifelong hormone treatment. In those men who we don't have metastases, where it's just the PSA count that's rising, despite the original treatment and the salvage treatment, well, in this situation, we have a choice. We can just either monitor and wait until there's a problem and then treat, or we can start hormone treatment, but use it what we call intermittently. Give it for 6 months to a year, then stop. And usually when we stop, maybe 2-3 years later, the PSA count may go up again, and then we can do the same cycle. So we can do intermittent hormone treatment many, many times over many years, as long as we don't have metastases that are visible on scans.
You touched upon the men who the secondary effects are intolerable. Let's touch upon those that might not be intolerable, but might be quite uncomfortable. What would you say to those patients who are concerned about the side effects? And is there any recommendations? Is there anything that they can do to help with that?
Yeah, that's an important point, because oftentimes the hormone treatment is for many, many years, and the side effects can be cumulative over time. And some of them are quite important to try and mitigate. So there are sort of the nuisance type side effects, which are the hot flashes. Patients put on a little bit of weight. However, the more important side effects are fatigue, loss of muscle mass, loss of strength. Some men experience mood swings. So the type of side effects that the man may notice are varying. However, there are side effects that the man may not notice, but it's occurring, and therefore it's important that a doctor checks. So, for example, patients can have their lipid profile change. They can develop metabolic syndrome. And these things are insidious and therefore needs to be monitored. We normally recommend for men that are starting hormone treatment, first, the doctor, the urologist or the oncologist needs to communicate with the patient's family doctor to inform them. Second, they should have, probably twice a year, a full blood work to check on a variety of things that we normally do for men that are aging. We ask men to remain active, at minimum 30 minutes to an hour of walking per day. But if they can do exercise, whether it's supervised exercise or not, it would be very helpful to maintain their strength and their energy level. That's all very important. Finally, one thing that occurs to men as well as women who are aging, and especially men who are on hormone treatment, is their bones can become brittle. They can develop osteoporosis. So it's important that men at the same time take vitamin D and calcium supplementation, and have their bone density monitored periodically.
And what do you say to those patients who just say, Dr. Aprikian, I can't do it, I want to stop?
And that's perfectly fine. So whenever I start hormone treatment, I tell them my preference, but I tell them that if you have the side effects that are not tolerable, and if I can't somehow help mitigate those side effects, it's perfectly fine to stop, even for a short period of time. However, we need to understand that when we stop, we allow the cancer to wake up. Sometimes when it wakes up, it's not so easy to put back to sleep.
And can some of our patients actually develop a resistance to this hormonal therapy? Can they know that this is just not working for them anymore? Is there a feeling? Is there something that they should be aware of?
So again, the good news is that the blood test can give us a lot of information before a man notices that something's wrong. So it gives us a signal many months in advance so that we can act before the patient gets sick. So yes, unfortunately, the hormone treatment most of the time is not able to control the cancer forever. But after a few years, the cancer learns, adapts, and starts to grow again. And the first signal is a blood test that shows the PSA count is no longer 0 and it's slowly rising. When that occurs, we do tests to see if there's something visible somewhere. And then we have options when hormone treatment is no longer enough. This is called the castration-resistant phase. And then depending on where the cancer is recurred, how much the cancer is recurred, how healthy is the patient, we have a variety of options to help with that patient.
So tell us some of these treatment options for this kind of patient.
Yeah, so the good news is that there's multiple, whereas only a few years ago, we did not have so many. So I mean, the research in this field has exploded, and the benefit to patients in the addition of years of life has been tremendous. So I think that's very important to recognize. There are a few options that go from simple to complicated. So the first thing we can try is adding another form of hormone treatment on top of the existing hormone treatment. These are usually in pill form, in tablets, which can oftentimes bring the PSA back down to 0. So that's the first one. And there are a variety of drugs that are available in that setting, and the physician can see which one is most appropriate for a particular patient. If, however, there is a cancer that is a bit more advanced, we see, let's say, a lot of metastases in the bones, or particularly in other organs like the liver. There we get a bit more nervous, and in this setting we have the option of using chemotherapy. So that's intravenous medication, usually given about every 3 weeks. So that's very successful in controlling the disease. We can often add what we call spot radiation, or we can target specific areas that may be causing symptoms, pain. For example, if someone is having back pain because of cancer that is now growing despite the hormone treatment, well, in addition to those treatments I mentioned, we can radiate specific areas to bring that under control. And we have new treatments now, new treatments that are recently, in the last 18 months, have shown benefit. So for example, there's a particular drug that can be given orally in tablet form that targets those men who have a type of cancer that carries a mutation. So now we're getting quite sophisticated in the realm of precision oncology. So if we can figure out if a patient has a particular type of mutation in their cancer, there's a drug that's available that works remarkably well in those patients. Unfortunately, the number of people that carry that mutation is not very high. So I would say about 20% of the men would be eligible, but that's available. And then we've got a new treatment, which is quite exciting, and it's linked to the PSMA scan that you asked about earlier. So earlier, I spoke to you about how we can use that antibody to go and find where the cancer cells are hiding. Well, obviously, someone very bright thought, well, instead of just adding a little signal, why don't we add something that can kill cancer cells? So there is now treatment that is based on the PSMA antibody. So a patient can get an injection intravenously, and that antibody will deliver sort of like a bomb to the cells which are expressing the cancer antigen. So as you can see, there's a variety of options here. for those patients whose cancer is progressing despite traditional hormone treatment.
Unbelievable. It gives so much hope to hear that there's so many options, because we all know that no cancer is alike, no person is alike. You did mention something that caught my ear at the very beginning of all those options, is you were talking about a new kind of hormonal therapy, and you said we can add that on to the hormonal therapy that the patient is already on. Is it important that they do both?
So, again, that's another excellent question. Today, and this may change over time, but today we feel that if a patient has cancer that has recurred, and we see cancer we see the metastases either in the bones or other organs, then we no longer just give traditional hormone treatment. We give both. We do the combination of the traditional hormone treatment and the newer forms of hormonal therapy, which are in tablet form. So we combine them so that we maximize the amount of hormone treatment we can give. If, however, someone does not show metastases, we don't see cancer in the bones or in other organs, and it's just based on the PSA count that's rising, in that setting, we just give the traditional hormone treatment at the moment. It's possible over the next few years, as research advances, that we add that newer form of hormone treatment in this early setting, but it's not the case today.
Okay, and does this newer form of hormonal therapy actually help you find or helps us delay metastases?
Yes, so that's the goal of the more intense the hormone treatment, or what we call maximizing the hormone treatment, we delay the progression of metastases, and we delay what we call the castration-resistant phase. We know that once you reach the castration-resistant phase, then despite all the options which are available, which is great, but then we know the disease is sort of getting stronger and becomes a bit more hard to control. So before they become castration-resistant, if we can delay that time by adding the newer forms of hormone treatment, then that's better.
Well, early detection is always the best, which is why I'm sure you're saying 2 blood tests a year to make sure that we're on top of everything. You keep mentioning PSA. It is the most important word of this evening, I feel. I know that there is a issue when that PSA is doubling. Can you tell us why is that so important to know?
Yeah. So it's quite intuitive. In someone who's been treated for prostate cancer, the PSA test becomes very, very powerful. And as long as it's 0 or it's flat, we know that everything's okay. When the PSA starts to rise, that tells us something is happening. We get worried that the cancer is either coming back or is waking up. Well, the rate of change of the PSA, or what we call PSA velocity, or the PSA doubling time, the shorter the doubling time, or the faster the velocity, the more dangerous is the cancer. So we pay attention to the rapidity with which the PSA is rising. So just to give you an example, if a PSA count is rising or doubling within 3 months or every 6 months, we get very nervous. If the PSA is rising very slowly, where it takes 2-3 years before it doubles, then we're much more reassured. It doesn't mean there's no cancer. It just means the cancer is not aggressive and we have time to act. But those whose doubling time is quite short, we get nervous, we do a lot of scanning, a lot of tests, and we usually intervene with hormone treatment, at least very early.
It makes sense when you know anything about biology and about how cells reproduce quickly. Like as a woman, it's pregnancy. You want to see that number double. So in this case, PSA, you don't want to see it double in a short period of time. We want it to be slow
Yes.
rising, and we want to make sure that we keep our heads above water when it comes to our PSA.
Yes, maybe just to add something, because I see this often in the clinic. When the PSA counts are very, very low, I find men get anxious with small changes. So for example, a patient whose PSA is 0.2, and then the next PSA is 0.23, and the one after is 0.24. Yes, a man looks at that, or a family member looks at it and says, oh my God, this is terrible, it's rising. But at those low levels, this is nothing to worry about. So really, a patient should not get nervous unless the doctor is getting nervous. It's when the PSA is in higher numbers that then we pay more attention to.
From a 1.6 to a 3.2 within, that would be scary.
Yes, that's not good. The numbers are still low, but it tells us something is coming and something is coming faster, and we need to act.
Okay. Let's talk about acting, because I know that we've talked about recurrence after first-line treatment. We've talked about radical surgery, radiation therapy, even standard hormone therapy. The next question that I want to tackle is, when cancers keep progressing despite treatment, what do we do then? What would you, as the urologist sitting in front of my husband, say when we get to that bridge?
So it depends. In those men who are still in relatively healthy situation, the suffering is not great, and are willing to try again and keep trying, there are what we call clinical trials. So research opportunities where we want to try something that has yet to be proven benefit. So that's something that's available, and many of the hospitals in Quebec offer a variety of clinical trials for men who are running out of options. So that's one good option. In terms of treatments, we can always do what's called palliation. So even though we may not have a treatment that is going to prolong life, but sometimes there are treatments that can alleviate suffering, even if it doesn't add months to someone's life. If we can alleviate the suffering, that would be helpful. So it's important that patients who are running out of options are connected with good supportive care services, where whether it's pain medication management, managing side effects of existing treatment, radiation to areas that are causing trouble. These are all services that can help alleviate suffering in the end of life state.
Is there a timestamp on how long it could take prostate cancer to metastases?
So no, and it varies. It can go very quickly, or it can take many years before it metastasizes, if it's going to metastasize. Again, the PSA count and the rate of rise of the PSA count can give a hint as to when that's going to occur. So in men who had surgery, for example, and 5 years after, 6 years after surgery, the PSA is starting to rise very, very slowly. If that rise is very slow, meaning it goes from 0 to 0.1, and then it stays at 0.1 for a year, then it becomes 0.2, and then it takes another year before it becomes 0.3. Well, this patient, we know, is going to take a long time before there's any trouble. So we can reassure the patient that he's really not in any danger. However, as you pointed out earlier, those that are doubling very quickly, then we know that if we don't do anything, the metastases will show up within a year or two, and therefore we need to act.
So how do we act? Oh, sorry, go ahead. I was jumping ahead there.
I just wanted to say that the PSA count and how quickly it's changing helps in a variety of states in a man who has prostate cancer. So that's important. The second is the type of cancer that we were dealing with at the outset, the famous grade or the Gleason score. So we do know that those people, those men whose Gleason score or grade was very high for what we call high-grade cancer. Well, we know that if you had high-grade cancer at the outset and your PSA count starts to rise after surgery or radiation, that's a particular group that we get nervous about, that if nothing is done, metastases may show up soon. And to answer your question as to what do we do, well, we look very hard with scans and maybe even the PSMA scan to determine where is the recurrence, so that we can either target, we either do hormone treatment or we do salvage treatment.
Can you talk about precision medicine, how that is actually working for candidates maybe of this type of cancer? Are the metastases, metastatic, there we go, castration-resistant prostate cancer patients the ones that would be looked after in this way with precision medicine?
Yeah, so precision medicine, precision oncology is being applied now more and more across a variety of cancers. We have the ability now to take a tiny piece of someone's cancer and determine some of the important, what we call molecular changes that are driving that particular type of cancer. Certain genetic changes in the cancer give us a signal as to how we can treat it. So for prostate cancer in the castration-resistant state, and again, this will probably be used earlier in the trajectory of prostate cancer, we can take a piece of the metastasis, or we can take the biopsy material that the man had many years earlier and put it through some fancy laboratory tests. And if we find a particular type of mutation in a gene in that cancer, then we have treatment that's available for that specific genetic change. This is new and is quite exciting. That specific genetic change and treatment was already being used for ovarian cancer, for example. The gene, for example, that we're looking at is the famous BRCA gene, which is commonly used for breast cancer. So we now see in oncology that there are genetic traits that cut across a variety of cancers, and we have precision-targeted drugs that can affect that. Over time, we will identify other genetic changes and develop drugs for those specific mutations. And it's conceivable that we can control cancer with a cocktail of medications, a mix of which target whatever precision mutations that a particular person carries.
Dr. Aprikian, we just came out of a pandemic where the vaccine was our solution. Is there a preventative or a curative vaccine to prostate cancer? Is that something that could be in the works?
Well, there's a variety of research going on to try and prevent all types of cancer, not just prostate cancer. Not the traditional form of vaccine as we had for example, the pandemic. However, the technology used to create the vaccines that we used against COVID-19, that same technology can be used to target particular types of cancer. So it's not really a vaccine, but it can be used as treatment. In terms of prevention, we don't really have a good way to prevent yet the dangerous forms of prostate cancer. So the best thing that we can do is make sure that if a cancer is going to develop, that we pick it up early. And Fortunately for prostate cancer, that can be done with a simple blood test. We don't need fancy imaging or other tests. A blood test can be oftentimes enough. So we encourage men to talk about prostate cancer detection with their family doctors, to have a PSA count done, and that can save someone's life.
And we tell them, even though the cancer may come back and may be recurrent, the fight is not over.
Correct. It's certainly not over, but earlier on I said there's probably a 20-25% chance of recurrence in general, but that's because those people that have a recurrence, their cancers weren't picked up early enough. So if we pick them up early, the chance of cure is above 90-95%. That's what makes the difference.
Let's talk about, this is PROCURE's Health Talks. As we know, PROCURE is very focused on advancing research. What is the current focus right now of prostate cancer research?
Well, it can't really be put into one sentence. The breadth of research spans from understanding how the cancer grows, how it spreads, to how it develops. The research covers areas such as how to find it early, how to detect it in certain parts of the body, and then a variety of new treatments. So it's very wide, the breadth for research. Probably the area that is the most active for all cancers is the ability to determine in a particular person what drives that particular person's cancer, and that is different than someone else. So getting back to the whole field of precision medicine, precision oncology, we know that you can have two men, same age, same lifestyle, same looking cancer on a biopsy, same grade, same PSA level, yet in one person the treatment is successful and the other one it's not. And that tells us there's something that we're not able to see yet, but the research tools have become so sophisticated that now we can drill down and find small differences between those two people and be able to use that information to target treatment better.
So many advances in technology. Just in our talk tonight, you talked about things being as recent as 18 months ago and how exciting all these new options are. I have to say, compared to when my father was a urologist 25 years ago, the longevity of someone with prostate cancer has completely changed. Men survive at greater numbers than back then.
Yes, indeed. First, when I was in training, most men would present with prostate cancer in an advanced stage. They would know they had cancer because they developed back pain or had trouble urinating, and the doctor would do tests and find that the cancer had already spread. That was a common form of presentation. Today, that's not so common anymore because of the PSA test. So that was a big, big advance in reducing the number of men dying from prostate cancer. And of course, there's been a lot of developments since your father's time and since my early days in training in treating the cancer. Now men who have advanced prostate cancer in their bones, can live several years, whereas back then it was several months. And all this is due to science, but more so in men accepting to be part of clinical trials so that we can try out these developments on humans, on people, and determining which ones work and which ones don't. And it's thanks to those men before that we learned about the new drugs that are available today.
I think also due to the fact that we are talking about the topic just like we are right now, that brings men to actually go in and do those blood tests. In the past, if you were feeling good, why would you even go to the doctors?
Yes. So men have notoriously been sort of reluctant to get checked in general, and then particularly for the prostate, because men felt some kind of shame to go through the digital exam. But that's pretty much over now, I think. I think men are now sensitized. Their family members, their partners know about prostate cancer, know about men's health issues, and push their male partners to go get checked. So the stigma is no longer as it was many years ago, and that's thankful to a lot of the high-profile people that suffered from the disease and talked about it, and so that's helped get the message, and to organizations like PROCURE and others that are there to raise the awareness and the importance of getting checked.
And to doctors like you who agree to come and talk with us on such an important topic. On that note, I think we have covered most of what we would have wanted to talk about. Dr. Aprikian, thank you so much for giving us some of your precious time to talk about recurring prostate cancer and the options and how the fight is not over if someone finds out that they have recurrent cancer. I will note twice a year that my husband should go get blood tests, and that the PSA doubling time is the most important, but not to worry if it's in the low numbers, right? That's what we should remember the most.
Yeah, so those, that twice a year and the rate of rise is really for men who have been diagnosed with cancer. For those who are okay, once a year in a regular checkup with their family doctor is plenty.
Duly noted. And we do know that questions can pop up at any time. If you have a question, may it be between appointments, know that PROCURE is here for you. You can reach us on our support line 7 days a week and speak to one of our health professionals. Thank you for joining us.
We warmly thank our experts and our partners for making this webinar possible. To find out more about the tools and resources available to you, or to make a donation, visit procure.ca. Thank you for your support.